We have a talk today, and we're very, very privileged to have both Ed Beveridge and Claire Jones here from the Royal College of Psychiatrists. And the title of their talk is Better Futures, a prevention-based life course approach to closing the mortality gap. So Ed is from London, and he trained at Fitzwilliam College in Cambridge and Magdalen College, Oxford. He took psychiatric training in North London and has worked as a general adult psychiatrist in inpatient and community settings since 2008. Ed is also clinical director for hospital services in Barnet, Enfield, Haringey, North London Mental Health Partnership, and he's worked on improving the physical health of people living with mental illness for over 10 years. He's led improvement initiatives at local, trust and ICS and regional levels, and he was trust lead for the physical health and mental health services at now CNWL. I'm not sure I can tell you what that one is. Maybe something about West London, Northwest London, don't know. Perhaps we'll have to get Ed to tell us what that is in a second. And he's the co-chair of the Pan London Physical Health Leads Network and previously led a regional improvement initiative with Healthy London Partnership. He is the clinical lead for mental health at UCL Partners, Academic Health Science Network, and honorary associate professor at UCL. He has taught and widely presented on the subject of improving physical health in people with severe mental illness, and that's how we came to be connected in the first place. And his key objective is to reduce premature mortality among those living with mental illness by addressing health inequality and inequity, promoting better access to health and care, and improving the parity of esteem between physical and mental health care across the health and care system. He's passionate about the power of co-production with experts by experience as a driver of better care. Ed, I don't think I've ever had a more impressive bio submitted. So I think that's going to have to go in the Hall of Fame of accolades to beat. I think we should have
the hall of needs an editor.
Well, it's actually quite an impressive thing that you've done there. So go on. No, CNWL. What is it?
Okay, well, fun fact, hot off the press. So that's Central and Northwest London NHS
I was
Foundation
getting there
Trust.
with the West London, yeah.
Yeah, and I'm actually going back there at the end of this month. I've got a new post there as a medical director for their big mental health division. So very excitedly, I will be going back to my old employer in the very near future.
Oh, that's really cool. Well, congratulations. So then we're going to move on to Claire. So Claire is an ST6 trainee in general adult psychiatry working in Southwest London. Claire is one of the current physical health scholars at the Royal College of Psychiatry. She has had a varied career pathway to becoming a psychiatrist, including many years working as an anaesthetist in acute trusts. So Claire, we have known each other for quite a while now, and I did not know that bit. That's interesting. So during her time in psychiatry, Claire's been shocked and saddened in witnessing at first hand the disparity in morbidity and mortality that is seen in our patients. This has led to her during her psychiatric training to develop an interest in how she can help the teams that she's been working with improve the physical health of their patients. She is using her time as the physical health scholar to contribute to joint projects, including writing the physical health position statement for the Royal College, which is what this presentation is about, and ongoing work looking at preventing antipsychotic related weight gain and input into the development of guidelines for treatment with clozapine. So welcome, guys. I know we know each other quite well anyway, but I'm just going to hand over to you. Like I said earlier, for people who've just joined, if you have any questions, just put them in the chat as Ed and Claire are talking, and we'll come to them in turn at the end. So in the interests of getting on with it, I'm going to pass over to you.
Okay, well, thanks very much, Jo, and thanks very much for that introduction. I am going to kick off and then Ed's going to take over about halfway through. So I'm going to talk to you today about the Royal College's position and our position statement that, as Jo correctly alluded to, myself and Ed have been writing. And I think when Jo mentioned the title, she said Better Futures, and I think that's what we're all hoping for, and I hope that that's what you're all here for, to hear how we can get a better future for our patients.
Gone on mute.
Claire, you're on mute. Don't know how that happened.
I don't know. Am I back?
Yeah, you're back. Yeah.
Did you
So
hear
start
me?
again. Start
Oh,
again with this slide. I think that you meant
oh,
to mute
okay.
on this slide.
So I'm sure you're all aware about this stark statistic and have seen this, the fact that our patients are dying are 20 years younger than the rest of the population. Now, within this talk, I'm going to say SMI, so severe mental illness, but actually what I'm talking about and what the cohort of patients that we cover in the position statement are people with mental illness, neurodevelopmental disorders, and neurodegenerative conditions. And so I might refer to SMI, but actually I'm covering that whole cohort of patients. And what we do know is, and as I said, you've seen this figure of people dying 20 years younger than the rest of the population, but actually there's pockets of people who are dying much, much younger. If we think about the general population, 85% of the general population live older than 65 years. But actually, people with intellectual disability, only 38% of them live to beyond 65 years. So that's a very stark statistic. And the deaths that are occurring are usually from preventable illness. And this is something that we at the college feel is unacceptable. And we want to look at the reasons why, and that's how the position statement sort of came about, that we identified there was a need for us to do something. So what we do know, and what we looked at the beginning when we started writing the position statement, was the fact that this is a situation that is getting worse. This mortality gap, so this gap between when our population die and when the general population die, it's getting worse. We know that it starts early, and we know when I mean that, so starts early in somebody's life course. We know that it's quite complicated, because if it was easy, we would have sorted it out now. There's often multiple intersecting causes as to why someone with mental health conditions might die before the rest of the population. And we also know it tends to come from this position of inequality. So we started writing our position statement, and it's had multiple different titles. I think the current title at the moment is Better Futures, a whole system life course approach to promoting healthy lives and preventing premature death. And the key points that we've been working on when we've been drafting this document is, as I've just said, the fact that the mortality gap is getting worse and it's not better, and it's coming from this position of inequality. The fact that we need to be acting at an earlier age, and I'll come on to that in a minute. We proposed a new model for how we need to be, I suppose attacking is the right word, attacking this problem. And I'll go through a diagram in a minute about the life course approach that we hope that the college will take on this. And we also identified the fact that, as I've spoken about, some groups within the SMI population face even further inequalities. So how can we help them? And also the fact that there's a lot of physical health conditions that we as psychiatry or the mental health community are not addressing. So those are the kind of the key points that we wanted to get to. And perhaps if there's a bit of confusion with them now, hopefully by the end of what I've said, hopefully it'll become a little bit clearer about what I mean. So, for instance, there are specific groups, and I alluded to patients with intellectual disability who are particularly worse off from the physical health stakes than a lot of other patients, even within the SMI group. But we identified specific groups that we wanted to look at particularly, so we could ensure that their equality was particularly brought up. So women, older people, children and young people, intellectual disability, neurodevelopmental conditions, and eating disorders. So within our piece of work, we've specifically looked at those groups. One of the things that I didn't realise before I started this piece of work, that actually not all of the deaths that are occurring in mental health patients are the direct result of cardiometabolic conditions. I think within psychiatry training and within mental health, there is an increasing awareness about cardiometabolic conditions. And what I mean by that is the fact that lots of our patients are on perhaps antipsychotic medications that can lead to them putting on weight, developing diabetes and heart problems. And most psychiatric services do have some sort of cardiometabolic clinic, at least as a minimum, monitoring perhaps weight or blood pressure. And so there is a little bit of awareness about that. But what I was less aware of is the fact that there is a huge increase in morbidity and mortality from what I put in inverted commas, unexpected causes of physical health conditions. And what I mean by that is the fact that, for instance, we don't really think of cancer as a mental health problem, but actually it's one of the leading causes of death in our population. Why is that? And also, I suppose on the flip side, why is it important for psychiatrists or people working in mental health to be aware of that? Well, the fact is our patients are not really being diagnosed with cancer because they're dying from it. And this is because they're not following the normal pathway from people having their screening through to diagnosis, through to treatment. They're just dying early from it. If we look at the uptake of screening, we can see that, for instance, patients with SMI who are offered breast screening, only 48% of them take it up, as opposed to 60% within the general population. And we know that this is, and again, this comes down to equality of access. We know that this is even worse in deprived parts of the country and in people of certain ethnicities. So by highlighting this as a problem, it becomes something that we can then think about, well, what can we do about it? And it's not all doom and gloom, because in certain parts of the country, for instance, in St George's, there is now a sort of link pathway between mental health and the cancer, the cancer screening and treatment pathways that GPs and mental health services can refer to help support people in their cancer journey, especially if they've got mental health problems. So a sort of link, a bit of a bridge to help them get to their screening, their diagnostic appointments and their treatment appointments. And I think Ed will perhaps cover it a little bit later in the recommendations. We don't want to rewrite the rule book. If things are happening that are good in certain parts of the country, we want that to be across the country. So if we're thinking about cancer, we want to be looking at how, I'm suggesting how we can integrate services, how we can reduce diagnostic overshadowing, and how we can make adaptations to the services that are already on offer. So, for instance, other things that perhaps you wouldn't think about that we've covered in the position statement are access to palliative care, the importance and access to lung health, liver disease, oral health, and neurological disorders. And by flagging them up and by flagging up the special groups, we hope that then that will be something that can increase the equity of access for all of our patients. So at the beginning, I spoke about this life course approach. And I suppose another way, we've chosen the word life course, but perhaps a life cycle would be something you've heard about in the past. But life course approach is the term that we've decided on. So we very much want to take this prevention, early intervention, preventative care, support to access to treatment, learning from outcomes, with a view that hoping this is going to prevent further deaths. And let me give you an example of what I mean by that. If I was in a community clinic and I had a patient come to see me, perhaps they were 55, perhaps they weighed 120 kilos, perhaps they'd already developed diabetes, high blood pressure, and perhaps also angina. They've perhaps been on olanzapine for the past 10 years. Already that person is in a very difficult physical health position. And actually getting them back to a position of health where you're going to have improved their physical health conditions, lost weight, had discussions about different treatment options, it's going to be very, very difficult. So what we suggest, and one of our recommendations, is that we need to, firstly, we know prevention is better than cure, get in early. So we know that when mothers have SMI and they have an incident where their mental health deteriorates, we know that going forward, if we get in there early and we treat that mother's mental health, it does improve the mental health of the children. We know that if, say, a young person comes to the early intervention in psychosis service, if we can offer them medication discussions at an early age about which is going to be the least metabolically active medication, we know that that is a good approach for them. We know that if they come and they say they're smoking or they're drinking, we can get in there early to help signpost them to different services. And then moving forward into the proactive or the preventative care, if somebody then starts looking like they're going towards diabetes, perhaps you catch their HbA1c when it's in the pre-diabetic stage, we can then be preventative and we can be proactive about where we're going to support them to get access for their treatment. If further down the line there are deaths, which unfortunately is always going to be the case, so deaths from physical health conditions, we need to learn from those outcomes. What went wrong and what can we do differently next time? And when Ed speaks about the recommendations, hopefully you'll see how some of our recommendations from this piece of work fit into this life course approach. We've looked at the key principles and the key enablers as to how we can achieve this this new way of doing things. One of the things we identified early on was that we didn't want to just develop a piece of work that was just something that was going to sit on people's shelves and wasn't actually relevant to the people who were receiving the treatment. So we have involved people with lived experience, and we've actively engaged carers into their views and what they want from this piece of work. We want this to be continuous learning and quality improvement. And some of the suggestions are easy, some of them are harder, but we do know that we need to achieve this by trying to reach marginalised people, marginalised groups and reducing inequality. And much of this is going to be achieved by integration of care, through integration of medical care, but also through integration and working between different colleges, nursing colleges, medical colleges, and different multidisciplinary team members, all with a view to achieving parity of esteem. We, as I say, we don't want this just to be a piece of policy that sits on somebody's shelves. And when Ed speaks about the recommendations in a minute, he'll let you know that who the recommendations are for, and they are wide-ranging and they are diverse. But we've realised that the Royal College can't do this on its own. For instance, things like I've written at the bottom, digital and data. And maybe some of you are thinking, well, why is that important? Why is that a key enabler? Well, for instance, our computer systems, when I say the computer systems or in mental health services, don't talk to GPs digital and data services. They don't talk to the acute trust digital and data services. There's medications that I prescribe that then don't even get transferred onto the GP's digital and data system, and it becomes very difficult and very dangerous. So We have identified these key enablers: policy, research and development, implementation of innovations, resource allocation, and digital and data as some of our key points that we need to get put into place. And hopefully that links me nicely on to the recommendations that I think Ed is going to talk to you from there about. Ed, are you ready to take over?
I am ready, and I'm going to go off piste already. I'm very sorry, Claire, but can I ask you, do you mind jumping to slide number? This is where we discover we're looking at different decks, of course. Do you mind jumping to slide number 19? Would that be okay? And hopefully we've got the same. We've got the same
We
numbering.
do have this. Yeah, we do. Is it that one?
Okay. Yeah. Keep going. And keep going. That's the one. That's the one. Thank you very much. So thank you, Claire. Nothing like a bit of live theatre. So I suppose just a couple of reflections before we dive into talking about the recommendations. And I suppose as you were talking, Claire, I was thinking about what synergies there are actually between what we're trying to do and other big and small programs of work and policy. And I suppose if we think about the 10-year plan for NHS, well, NHS England, what we're suggesting is very much a fit with that. We are looking from pivoting towards prevention in as many ways as we can. We are looking at moving from analog to digital in as many ways as we can. And I guess, in effect, if you do all of that, you move your work from hospital to community, because because people with mental health conditions and neurodevelopmental conditions and neurodegenerative conditions often end up in the urgent and emergency care system, when actually, if you had done some more preventive work and enabled them to get the same interventions as the general population, then you would be seeing fewer of our patients in those urgent care pathways. And I think so this is a more sophisticated or more elaborate version of what Claire showed you before. And really, I just wanted to emphasize that we've divided the life course up into these 5 chunks, and that's how we've created the recommendations, starting from the point of primary prevention. So thinking about what influence can the Royal College as a professional body have on other policy areas than health. So what influence are we having upon housing and food policy and smoking policy and so on and so forth? And what work are we doing around prevention of mental illness in the first place? And later on this afternoon, I am at a meeting of the advisory group for the Public Mental Health Implementation Centre. And the Royal College is very interested in thinking about what can we do that will prevent long-term mental illness, because a lot of the risk factors for mental and physical illness are the same. So I guess there's a lot more that we could do in the prevention space to influence other policy areas. Claire talked about intervening early, and we mean early, as you said, perinatal, early years, CAMS. We've got quite a lot to say about that. Claire mentioned, what are we doing at the beginning of someone's contact with mental health professionals, rather than waiting till they are some years down the line. We know, for example, that people start to accrue long-term physical health conditions in the 5 years before they ever get a schizophrenia diagnosis, for example. So there's something going on over and above the impact of illness and the treatment for illness itself. Health services are not designed for people with mental illness. I think it's fair to say they're designed for the general population. So we can assume, and Claire has showed you the range of different conditions and pathways we've been looking at, we can presume that all of the pathways that the general population access are not adapted for people with mental illness or autism or intellectual disability. So we see in the evidence that things like access to screening, cancer screening, other national screening programs, vaccinations, population level preventive interventions are taken up less by people with mental illness. They're, often by a factor of 10% or more. So there's something that we who are looking after in contact with people with mental illness need to do to support them to access the same treatment that everyone else gets. And part of that involves thinking about how general pathways might be adapted in ways that benefit a wider range of population. And then, as I've said, there's something about what we learn from our outcomes when they're bad or our outcomes when we improve them. And I won't go through again the principles and the enablers, but you can see that they're on either side of that life course model. So all of that leads us to the recommendations. If you pop onto the next slide, Claire, I hope, yes, we're back in sync. Hooray, hooray. So we've come up with 25. That's partly because my brain works that way and I like a nice round number, and we've got 5 life stages and 25 recommendations, although it's not 5 per life course stage, but don't shoot the messenger. So I guess, as a Royal College, we're in a position to influence all sorts of stakeholders, but I've fought shy of telling too many people what to do. I don't feel like it's my place or our place to tell GPs what they should or shouldn't be doing, or nurses or other kinds of doctor. Although actually, when you engage with professional bodies of other groups, they are quite keen to get your steer on what to do. But I've really kept it in the sphere of people we can and should be influencing: policymakers, psychiatrists, mental health providers, people who commission services, academics, because I think we have a very direct role in influencing what they do in the mental health space. But we also are very, very keen as a principle to work with other Royal Colleges and professional bodies. And we've had some quite encouraging engagement with Royal College of Emergency Medicine and GPs and RCN, for example. So that's quite exciting. The recommendations are chunked up into the 5 life course tasks I've told you. They need to happen, they need to be doable, because unfortunately, as Claire said, there is a big risk that a document like this sits on the virtual shelf and no one does anything with it. And part of the reason for that is that it's very easy to say, well, that's all very lofty as an ambition, but that's never going to happen. And the way we've tried to future-proof that is by finding examples or resources where the thing we're recommendation is already happening. So we can say that this kind of service can be set up because it exists in Leicester or it exists in Cornwall or whatever. So we've been trying to get as many examples and good practice examples and resources and so on from as many sources as we can, so that we can actually flesh out the recommendations, which give a high level objective, but then a number of sub recommendations that sit underneath it. And I guess what we're encouraging is a huge suite of very small changes across the whole system, which all build up which all contribute to eventually reducing this mortality gap. So if we just move on, I'll give you some examples of what we mean so that you can get a bit of a sense of what I am potentially waffling about a bit. So in the first life course, so this is the prevention one of our recommendations is that general population health check, screening and vaccination programs offer equitable access for our population and their dependents. The reason we say dependents is because if you have parents who have mental health challenges, they are potentially going to struggle to make sure their children get their vaccinations as compared with parents who don't have mental health challenges. So we're very keen to make sure that what benefits our patients also benefits people they depend upon. And so we've come up with a suite of different ways in which that high level objective could be achieved. Moving on to the intervening early part of the life course, we've said embed physical health monitoring and preventive interventions into mental health care for children and young people. So actually thinking about service specifications for inpatient and community CAMS, for example, that's child and adolescent mental health services. I think we flashed through the child and adolescent version of the Leicester tool, but we have some really good enablers for this and some fantastic buy-in actually from children and young people's mental health within the college and within NHSE and so on. So quite excited about what we have to say about that, because if we're able to prevent more at the really early stage of childhood or adolescence, then we will grow, I think, a healthier generation of adults despite their mental health challenges. Then moving on to the next life course stage, which is proactive care for people when they come into our services. A really obvious one, which we don't do very well, is to ensure that psychotropic medication choice is tailored from the first presentation, and that antipsychotics and mood stablers are reviewed annually by somebody who might change them, because I think a lot of medication review is checking that this can be in status quo rather than seeing somebody who's really going to take an active role in optimizing, reducing, switching to make sure that people do not continue to gain weight or struggle to lose it, for example. And I think there's a lot that we can do to get the choice right early on. There's some really good digital enablers to make medication choice more tailored, and again, we reference some of those in the document. Then when we're talking about people who have started to develop conditions, physical health conditions in the context of a mental health problem, we think all programs for treating complex long-term conditions and multimorbidity include, as a standard part of their specification, support and adjustments for our population. We know that people with severe mental illness, for example, develop multimorbidity, that's 2 or more long-term conditions, far younger than the general population. So we need to be thinking about, if your ICB, your commissioning area, has a multimorbidity program, does it reach the younger people with SMI that it needs to, who should be thought about within the cohort? Or indeed, does it include SMI or intellectual disability as one of the factors of one of the long-term conditions or comorbidities within your scope? And then finally, the 5th life stage, which is about what are we learning? That's all right. We really want to create a generation of professionals, not just psychiatrists, but mental health professionals who think this is their problem. I was speaking earlier to somebody who's doing some health education research around this, and we were talking about how we can use curriculum and other such enablers for psychiatrists. And I think what I would really like to see in the next 5 to 10 years is a generation of psychiatrists who are thinking not just about someone's risk of taking their own life, which is a huge part of what we do, but also somebody's risk of dying younger than they need to because they haven't had the opportunity to have cancer screening or to give up smoking or to receive GLP-1s if they need them, et cetera, et cetera. So I suppose I would really like to create a bit of a paradigm shift within our profession so that people think that preventing early death from physical health problems is as much their job as everything else. So I think, Claire, is that our last slide with our contact details on? And we're both always very happy to be contacted, and you can find me on social media if you have an appetite for drivel, as I tend to put out. But we can probably unshare the slides and hand back to Jo, I think.
Drivel, interesting. So thank you very much.
I specialise in drivel.
So I'd like to show some appreciation to Claire and Ed for sharing that with us. You can either do that through the virtual React things on there, or you can just be old school like me, because that's just my age, and you can give them a proper clap. Thanks, Lauren, because you're obviously nowhere near my age, because as we established earlier. Thank you. That was absolutely fantastic. So if people have any questions they want to ask, please pop them in the chat. And this is to allow me to screen. I run a few of these kind of things, and it's always helpful to screen questions before they are posed to the presenter so we can make sure they're on point. But Ed, whilst people are having a think about what it is, and I can see a couple of people typing there, I just wanted to pick up on, I think it was your last point around whose responsibility the physical health is, and you spoke a lot about psychiatry. And one of the things I think I've become aware of since I've been working in this field is I think it's everybody's problem. I think it's a wide multidisciplinary problem. And I think if I was to do a straw poll and say who's in the audience now, we will probably get a lot of dietitians, a lot of pharmacists, and maybe some psychiatrists. And what I would like to see is more OTs, more physios, more physical health nurses taking on that collective responsibility. Whenever I've sort of spoken, especially about weight gain, because obviously, that's the side effect that I've been particularly interested in, pharmacists and dietitians really kind of get into that and feel that it's like part of their responsibility to sort. But I actually think it's wider, because there's so much that can be achieved through bringing in that wider MDT, and a multidisciplinary approach has to be the way to go. So that's just my 2 pence. Have we got anything in the chat yet? Let's have a look.
I'll just come back on that while you look, because I agree, and actually I suppose if you go to a mental health trust, the people who are looking at physical health are nurses, OTs, and other AHPs. Getting psychiatrists interested in this is a real challenge, and that's partly why I'm really pushing that, because I think we need to get our own house in order, as it were, and pharmacists, absolutely. So everyone but us, it can sometimes feel. I would like to think that that's changing, but I think a lot of the conversations I had 10 years ago are around, this is not our job, it's for GPs, and they never do what we tell them to. We're sort of moving on a little bit from that, but still there's a lot of stuff around where does the boundary sit, and the answer is nowhere in particular. But Claire, as a younger generation of psychiatrists representative, are things shifting, or are we back in the dark ages?
I mean, I think there has been more recently. I think, from the 10-year plan, there's the sort of make every contact count, isn't there? Which I think is, anyone who speaks to someone about anything to do with their mental health, if they then mention their weight, it's always a good opportunity, or they mention worries about this physical health or that physical health. I think it's always good. And I think though there still is a reluctance to get involved. And I think that's really, really sad. But I think the GPs can't do it on their own. And equally, if we're prescribing medications that are significantly affecting somebody's physical health, we need to be taking responsibility for that, don't we? But equally, we need to be given the correct support. There's a lot of people who might want to do an ECG for somebody, but not necessarily feel confident about interpreting the results of it. So I think, as part of one of the things in the position statement, we spoke about there's some parts of the country that have got good access to getting ECGs that are done in the team reviewed very quickly, so we get quick results back to patients, and things like that to support psychiatry are essential, and then that takes the workload off the GPs.
I think primary care is struggling across the board with lots of fields. And I do wonder where the role for the new neighbourhoods might come in to help support some of that. But I mean, we could go off on a tangent, just us talking. So I think it's important that I open it up to the rest of the network now. So we've got a question here from Andrea around perimenopause and menopause. And I was absolutely astounded when I did some research recently for an article that the relapse rates for people with SMIs, for women with SMIs, they approach menopause can be quite significant. And actually, HRT can have a significant improvement effect. But if there's a challenge around getting HRT continued, as Andrea is suggesting, in primary care, then that poses a significant barrier to accessing equitable healthcare. Andrea, do you want to come on and we can, maybe have that conversation between the four of us?
Yeah, it's just, as I say, I work in an inpatient unit, and we've got a lady at the moment who's 47, so she clearly falls into that area, who is relapsing at the moment, but she's been on the ward for about 9 months now. So, if you're only a short-term patient, then fair enough. You can refer back to the GP and they can, prescribe the HRT. But this lady's been with us a long time, and she's likely to be with us a lot longer as well. But the medics on the ward won't entertain starting HRT because they fear that the doctors won't prescribe it when she goes back into the community. And I just feel, she was in the community, she could go to her GP and say, I want to go on HRT, and she'd get it. Whereas there seems to be a lot of hoops for her to go through. They'd say, oh, we'll have to refer on to a specialist. And, just
especially when HRT itself has such a beneficial protective effect. Anyway, that to me. Anyway, Ed, you come in. I just know from doing the research on it, I find heartbreaking.
It's absolutely timely that you mentioned menopause, and I'm about to do a name drop in a minute, so apologies in advance. So we know that people with SMI and intellectual disability, and people from some racial minority groups, in fact, get menopause earlier. It gets detected less well, and they have less access to HRT. So we've got a real, it's a really bad situation, actually. And as you say, relapse in mental illnesses and new onset of mental illness around the time of menopause are both recognised. And the Royal College has just released a new position statement, which I've just put into the chat, which aims to turn this around. So there are a number of recommendations within that. It's really nice being able to cross-reference work where, so we have 2 presidential leads for women's mental health, and I've been able to work quite closely with them on areas where our topics actually coincide, and this is one of them. So we had a launch event at the House of Commons where Davina McCall was very, very present and positive about this work. So I feel like we're in a position where that's recognised. My own view about whether we should be prescribing HRT on our wards, for example, and that's a big caveat about prescribing practice varies a lot. I think if we have got access to a patient and they have a problem that we can treat, we should be doing it. I can't think of a good reason why we wouldn't, particularly because something like HRT is not particularly difficult to prescribe. It's not particularly risky. You can always get advice from somebody if you're not sure. And I feel like taking the view that that isn't our problem to solve sits quite uncomfortably with me. I think, and I do, within my profession, there's a variety of views, and some people really, often people just feel unskilled and don't quite want to say that. So we'll say, I don't think this is for me to do, it's for someone else. But actually, I feel like when we have a person under our care with a problem that we can potentially fix, if we get some expertise when we're not sure, surely that's a better position to be in, particularly as the college is now taking a much more assertive stance around women's mental health and menopause in particular.
Yeah, I agree. I hope that helps, Andrew. I think one of the things that surprised me when I was looking into this and SMI, beyond what we call the usual suspects like the cardiovascular disease and everything else, is that there's just like everything else, there's so little research in this area. So there isn't enough really to form the guidelines around. But one of the things that did surprise me from the little research that is there is that HRT does seem to have a protective effect for women. And what can happen is that someone can be prescribed or have their dosage of antipsychotics or changed, when actually HRT could potentially solve the problem. So to me, that's not like you're treating the HRT per se, you're also treating what is perceived to be a relapse, which may or may not be a relapse. And I think one of the things that we urged in the paper that we wrote was just less diagnostic overshadowing and more markers, let's just see, are these women actually entering menopause and need some support or not? Right, so we'll move on. I think we've got Christine, who, I think talks about the physical health monitoring. Gosh, this is I feel like the needle hasn't changed on this conversation in 20 years. Who's responsible for the physical health monitoring, and how many audits have you all seen where the thing might be monitored but there's no action, even with an abnormal thing? So that happens quite a lot as well. So I've seen a lot of student audits around that. So I don't know. This is where I suppose I would come back in and say, is there scope for the Royal College to get involved in how the neighbourhoods are going to be developed? Is there something where this could be placed more centrally with maybe some mental health support, assuming neighbourhoods get off the ground?
I'll start, but Claire has done a bit of has been thinking a bit about neighbourhood and integration. So I'll hand over to you in a tick, Claire. But who's responsible? Okay. When you try and impose a boundary as to who's responsible for what bit of something, all you get is a boundary dispute. So, for example, if you go back to the 2010s, we had something called a sequin target for physical health checks. Sequin standing for commissioning for quality and innovation. And basically, there were targets for inpatient mental health, early intervention, and community mental health for what proportion of patients under their care needed to have their complete health check. And there were financial incentives, which were actually, you don't get money taken away, rather than you get more money than you have in your bottom line. And there were targets for GPs. What then happened was that NHSE tried to specify that for X period, the inpatient service, the mental health secondary care trust is responsible, and then they can hand over to the GP. What then happened was that every locality had a different conversation about what constitutes stable. So some people are saying, we'll take them when they're stable, but we think that's 2 years. Or you'll have another locality where the mental health trust are saying they're stable when they're discharged, and then we need you to take over. And everyone all of the energy gets sucked into thinking about this boundary, when actually no one's thinking about the patient as they continue their life, while everyone thinks about responsibility. So I think there isn't a concrete answer to where the responsibility begins and ends. I think the person who has the best access to the patient and can get the resource in to do the work should do the work. And so GPs are best placed for most of that, because they generally have access to patients. They have good resource they have resource and skill. I won't say good resource, because their resources have been absolutely obliterated over the years. But I think, there are a significant chunk of patients who either we have detained in hospital for years, or we're the only people we have access to, because that's our skill set in actually reaching people who don't engage with their GPs or other health services. We need to be able to do some of that work ourselves and have good integration with other people's systems to let them know that we've done the work and what our results are. But Claire, I don't know if you want to say anything about neighbourhood.
Yeah, I mean, I suppose, like you said, boundary disputes cause one thing, but actually the way to solve it is, like you said, about the integration side of things. And we have seen, and we give some really good examples of where integration has worked well in mental health and physical health services. We know that accessing physical health services for a lot of our patients is really, really difficult. And, by giving them a bit of extra support to get to their hospital appointments and things, there's a lot of positivity from the acute trust that actually that's going to reduce admissions into A&E and acute admissions. And we know that is what the acute trusts actually want. They don't want our mental health patients, in inverted commas, clogging up their beds, because it takes up a lot of resources. That's a horrible thing to say, but I think that there's a lot of feeling about that they don't want our mental health patients. They would much rather have some early intervention with them. And that's when Ed and I have spoken to the people from the acute trusts and spoken to different Royal Colleges. They would much rather have an integrated approach than have patients that they then struggle with, because a mental health patient who's having an acute crisis and an acute physical health problem, an acute trust is not the right, safest place for them. And I mean, I suppose I clogging up is the wrong word to say, but I think they can't deal with patients with mental health in the acute trusts.
Because their pathways are not designed for that patient group. They're designed for the general population. I think that, and I think that's absolutely right, Claire. And until you say, so can we shift some of your resource into this area of prevention, and suddenly it's all very difficult. But that's called so shifting left, as we call it. So shifting into prevention is absolutely essential to save the acutes, but you do need to move some resource out, because there's only a finite amount. So that's where the conversation about prevention gets a bit harder.
Some of the conversations I've had, both with colleagues in primary care, but also with patients through the research that we've done, is that there's a bit of a lack of skills and knowledge around SMI particularly. There's perhaps a little bit of fear around SMI. People don't know how to have those conversations around the physical health. And obviously the research that we did was specifically focused on weight gain. It just weren't raised. And I think that potentially is a piece of, like, maybe a joint thing like you're talking about earlier between the different colleges, but there's definitely I think a role for primary. But I know I've got, quite a few GP friends who are absolutely petrified of antipsychotics, who don't want to get involved in the prescribing because they find them too complex. I think it makes it very, very tricky. There's definitely some work I think that needs to be done on education across the board. Mental health about physical health, but physical health about mental health, I guess.
I think
Bring everybody together.
Like in the position statement, we do highlight like the fact that our patients do not have proper access to palliative care. Because palliative care teams are absolutely terrified of people with mental illness. They're terrified there's going to be a massive deterioration in their mental illness in a hospice, and that they're going to get stuck with our mental health patient. They're terrified. A lot of our patients have, coexisting drug and alcohol problems on top of their mental health. They're terrified about suddenly prescribing them different medications. So they then just, right, okay, you can't have access to palliative care. And that's disgusting. That's really, the people at the end of their life being denied proper care.
It's one of the things, again, I think I found shocking when I started to read all the stats around it. It's diabolical.
Particularly, I regret to say, as our patients end up needing it earlier than other patients as well, because it's a really, when you start to sort of think about the pathway, cancer gets diagnosed late, people reach the end of their lives prematurely, and then they get worse access to end of life care. So it's as soon as you start thinking about the implications of what happens upstream, it's quite difficult to kind of get your head round.
And it's across the life course. That was the thing that got me. It was not just restricted to cancer. You see exactly the same thing happening across the diseases, across healthcare. I think that was a bit of a shock for me as well. Go on, Claire, and then we'll move on to Sally.
Yeah, and I was just going to say, like, when we've had discussions with acute trusts and they've sort of said things like, well, why are you not just managing this patient in your mental health hospital? Why do they need to come to the acute trust to manage something fairly minor? There's a lack of appreciation about what can be done in a mental health hospital. There's very much, this lack of appreciation, the fact that there's not IV antibiotics, there's not this, there's not catheters, there's not, it really is, like you say, an education is needed, but with a bit of extra, I don't think it takes much to get that knowledge there for the physical health teams. And equally, I do know that recently a lot of the F1s, there's been an increase in the amount of foundation doctors that are coming through psychiatry. So hopefully that then translates through into the acute trusts by the fact these foundation doctors have seen how psychiatry works, what the limitations are in our systems, and hopefully that translates to a bit more understanding. Anyway, sorry, I'll let you go on, Joe.
And there's just, I don't know how many more. I don't scroll down in case I lose the ones up, but there are some more messages. But I just want to say, it sounds like, Sally, you have tried to do something innovative to improve screening locally where you are over the last 4 years, I think it says in the message.
Yeah, thanks, Joe. I'm Sally. I work in public health in CNTW, so Cumbria, Northumberland, Tyne and Wear NHS Foundation Trust. So we're the north of the northeast and North Cumbria, and we recognise that inpatients staying in hospital for a long period of time were missing out on their screening invites that would go to their home address. If they didn't have a home address, they wouldn't get one anyway. If they didn't have a GP, they wouldn't get one anyway. And we set up pathways with some of the national screening programme hubs in the local area to make sure that our inpatients could use we use our trust as their proxy home address for that period of time, because some of them were staying in hospital for well over 6 months, several years, and sometimes might be in there for the rest of their lives. So we've done that for bowel screening, breast screening, AAA. Some of the pathways are a little bit harder to kind of navigate than others, but sharing information has been quite a big barrier. Getting your data protection risk assessment forms submitted and filled in, and then obviously people are protective of information because of GDPR and all those sort of confidentiality rules, but we have got the pathway set up. We get kits, we send a list in once a month to our screening hubs. They send back information on who's eligible according to their list, and then they send us the kits for bowel screening. We send those to the wards, and then the ward staff support our patients to complete them if they're well enough to complete them. Results come back through to us, we send those back to the wards, and then any follow-up that's needed, if there's a positive screen or further investigations required, gets sorted out after that. And the same for breast screening with appointments. With diabetic eye screening and lung cancer screening, we've tended to do it in more of a cohort approach, because it was getting a bit too messy, for want of a better word, to have lots of different eye screenings going on. So we actually managed to get the eye screening team to come onto the wards and set up on the wards, so that patients that didn't have leave to go to appointments could actually and it was so much more accessible for not just for patients but for staff who are really busy and can't get off the wards. There's no staff, so it just made things a lot easier. So yeah, I would be interested to hear from any other trusts who've done it, because we haven't heard who is doing it, and it's always good to share ideas.
It's amazing.
Sally, before Ed jumps in, I just want to say I think this might make a really good talk for later in the year.
Yeah.
I'm going to put my email in the chat. Can you email me and we'll try and get a month at webs. I've just put you totally on the spot, so feel free to nominate a colleague.
I'll bring my boss along.
Very briefly, so firstly, brilliant, exactly what you should be doing, because people do lose access to cancer screening. Second point, drives me mad that we think it's more important to follow GDPR than for someone to get their cancer screening. The balance has really shifted in the wrong direction around that, and that's another day's conversation. Thirdly, keep your eyes out for the lung cancer screening program as the newest national screening program. We have the opportunity to shape it into something that's much more accessible. There's some really exciting work going on, certainly in London, and there's going to be an HSJ thought leadership piece out about it very soon, because I am going to a roundtable which will be generating it next week. So definitely keep your eyes out for lung cancer screening. I think it's a really big opportunity.
Thanks. Yeah, we're also really keen to try out some of the new HPV self-sampling kits and things, because we know that they're going to most deprived communities, but we haven't heard quite what the rollout will look like yet. But we're really keen to get those into our trust to support as many of our service users who might have often had a lot of trauma, sexual trauma, and that might just be the key to getting them to complete that screening.
Brilliant, thank you. Well, we've hit 1 o'clock. Ed, thank you so much for trying to reply to the people who we didn't obviously get time to. That was absolutely fantastic. We do have the GISC mail can be used, so that how you find out about these seminars in the first place. You can use that as a way of having a discussion. So if there's anything from here that you want to follow up, please do so on the GISC mail. Claire, I think you're a member of that anyway, so you can pick up if there's anything related to the Royal College on that. So thank you so much. Thank you for coming. If anyone has any suggestions for future talks, I have just completely put Sally on the spot today. So if anyone else would like to volunteer, we got, I think Lauren, is it July and onwards, is it? We need to sort. I think I'm a bit mixed up over which months. Yeah, July onwards. So we've got talks booked from now, every month from now until July. But if anyone has any wants to share, because I think one of the things that we can do is share good practice and let people see what else is happening out there, because we tend not to find out about it unless we see it written down somewhere. So this is one way that we can share different approaches to caring for the physical health of people with mental illness. So thank you so much once again to Ed and Claire. It's been enlightening.
Thank you all.
As usual.
It's been a pleasure.
Thank you very much, everyone, for turning up, and we'll see you next month. Well, I think next month, if I'm not mistaken, is on cervical screening, I think, in SMI. But we will advertise that as soon as we've got the details through. We have literally just secured the speaker a couple of days ago. So we'll let you know more on that as it comes through. Thank you very much, and see you next time.
Bye.
Thank you.
Bye.
Bye-bye.